Okay, welcome again everybody to Spine Prehab. My name is Tammy Kolosky and I am the spine coordinator here at Henry Ford West Bloomfield. Thanks for coming and being part of our class today. Some of you were given some additional forms to fill out today. Those are administered to us from an organization called MISIC, which is the Michigan Spine Surgery Improvement Collaborative. What we do with that information that you actually filled out for us is collectively we take a look at it over time. We have you fill out a baseline form, which is probably what you filled out today. You'll fill out another form at 90 days. You'll fill out another one at 1 or 2 years, just depending on what type of surgery that you had. We look at those forms and it helps us to make improvements and changes to your spine surgery. So those are really important, and thank you for taking the time to fill them out. I know they're lengthy forms. So I always show this slide simply because we also have a joint replacement class here at Henry Ford West Bloomfield, and I oftentimes get patients sitting in here who don't belong in here. So I'm gonna quickly just go through our surgeons. If for some reason you don't see your surgeon here, let me know, because you could be in the wrong class, okay? The first photo is of Dr. Shadid. Do I have any patients in here of Dr. Shadid's? Next one is Dr. Stephen Kalkanis. Do I have any Stephen Kalkanis patients? Next is Dr. Malik. Next would be Dr. Seifrid. Next is an ortho spine surgeon who also works here at Henry Ford West Bloomfield, and that's Dr. Graziano. Next we have Dr. Zacharias. Raise your hand if you've seen her before this class somewhere along the way. Dr. Schwab. Dr. Ayer, Dr. Chang, Dr. Pahuda, who's also an ortho spine surgeon who works here out of Henry Ford West Bloomfield as well as main campus, and Dr. Adam Robin. Anybody not see your surgeon here? Okay, you're all in the right place then. Again, welcome to Spine Prehab. Really our essence and the reason we do this class is to help you get through your surgery as smoothly as possible. One of the best ways that we have found to do that is by educating you beforehand. So we give you a wealth of information here, not just from a nursing perspective, but you'll also have a visit from an occupational therapist while you're here who will answer some really, I just think, in fact, I love her portion because it really helps with your activities of daily living, which really those are one of the things that are kind of most impaired after spinal surgery. So her information is very valuable. And at the end, if you happen to be a patient who's gonna actually need a brace, Stella Myers, who you saw here before class started, will come back and just briefly go over the braces, how to use them, how to clean them, that type of thing. So optimization consists of several things, but mainly it's this core educational piece that's part of optimizing you for your surgery and getting you the most ready that we can. There are some things also offered throughout the class, just some information that OT will give you today. If you take a look in your spine folders, there are some exercises in there as well. They're really beneficial if you could do those exercises before surgery. Some of you may not be able to do them because you're gonna have some limitations with the amount of pain that you're having before surgery. If that pertains to you, don't worry about it. These exercises will again come into play or in handy roughly 6 to 8 weeks after your surgery. They're a really good place to start in just kind of re-optimizing yourself after surgery. So they're useful before and or after, so that's why we've given them to you. You have a bunch of muscles between here and here, part of your core, so strengthening those is really beneficial with spine surgery. Again, welcome to Henry Ford West Bloomfield. I'm sure your surgeon has probably already at least given you a ballpark figure of, you're here just overnight, or you'll be here anywhere from 1 to 2 days. I don't want to give you an exact number because there are so many variables that sometimes keep you here longer, or sometimes when we think you might be here 2 days, you do so well and you're home within one day, 1.5 days. So not going to give you a number, but just hopefully your surgeon has given you some type of time frame to look forward to. Some important things to do before surgery. This is all the planning part. I kind of divide the program into some planning before surgery, things that will occur on day of surgery, things that will occur on post-op day 1, as well as discharge information that you'll need. So now we're starting with the planning portion. Some things that you're going to want to bring with you would be clean clothing, and comfortable clothing. You will most likely, if you're an inpatient here, get a visit from physical and or occupational therapy if your surgeon orders that. Outpatient, that's not the case. However, you're still going to need comfortable clothing because you all have to be transported home. So remember comfortable clothing. A list of your medications. So also in those folders on the left-hand side, there's like a sheet of paper that's bolded medication list. I do need you to fill those out. Bring them back with you the day of your surgery, okay? Fill them out accurately. Even if you're prescribed something, let's say you're only supposed to be taking it 4 times a day, but you're taking it 6 times a day. I need that on there, which is okay. We just want to know what you're taking, how you're taking it, when you took it last, okay? And bring that back with you. CPAP, do I have anybody here who uses CPAP at night? Bring your CPAP machine with you. Okay, we'll use it while you're here. One thing that's not on here, a photo ID. I know that just sounds really obvious, but just have a photo ID with you just in case anybody asks for that while you're here, okay? And so, some more additional planning steps. So weaning off of narcotics. You may or may not have been asked to do this already in the clinic. If you were, just know that the rationale behind that, the reason we ask you to wean before surgery, if you were one of those candidates, is just so that we could more effectively treat your pain after surgery. Okay, when you get down to a more minimal level of narcotic ingestion before surgery, the pain medications we give you here are much more effective. So if you were asked to do that, that was the rationalization behind that. There are also some medications that we asked you to stop anywhere between 7 and 10 days, some others between 2 weeks before surgery. The main ones that you could probably get from your outpatient pharmacy would be NSAIDs, a group of medications. We refer to them as NSAIDs, non-steroidal anti-inflammatory drugs. Most common would be ibuprofen, aspirin, naproxen, those types of medications. So you're asked to stay away from those about 7 to 10 days before your surgery. I do want to make an important notation though. Those of you that are having spine fusion surgery, you will not be able to take those same exact medications after surgery either. Your surgeon will hold those specific meds for, some period of time, usually somewhere between 6 and 12 weeks after surgery, and they'll let you know when it's safe to take those medications again. Tylenol is a really good drug of choice because it's safe before. We may even give it to you here, and it's safe for you to take it home. So that's a good one to have on hand if, as part of your preoperative planning. Are there any questions or anybody who doesn't understand the information regarding the NSAIDs? Do you know, Dr. Zacharias, is aspirin-free Excedrin acceptable before surgery?
It is.
It is. Aleve we would not have you take because the drug in Aleve is a non-steroidal anti-inflammatory. Okay? Yes, 7 to 10 days before surgery. Okay? Some other medications that we also ask you to stop are multivitamins. A lot of those contain vitamin E, so we would ask you to refrain from those as well. I'm sure in the clinic they give you a folder similar to the folder that you received today. And inside there, they have a really big comprehensive list of all the medications that might typically fall into the category of medications that we ask you to stop. Additional planning would be to review your advanced directives. Does anybody not know what advanced directives is and needs me to explain that for you? Okay, and also I do have some of those forms if anybody's interested in taking one with them today. I do have those on hand. Just ask me after class and I can give you one. Getting your pre-admission phone call. So this is something that also happens as part of the planning portion. We typically have pre-admission testing call you about 7 to 10 days also before your surgery. Okay, that should occur, yes. Advanced directives, I believe it's good until your next visit. So you have that ability to renew it every time you come here. Okay, it's not like you fill it out once and it holds fast forever. You can add to that, take away from that, change it anytime that you're here. Like I said, I have them here. You could also fill it out the day of your surgery. They'll know where to get that for you if you like, okay? And then one additional part of planning would be the OR area is going to call you before surgery. Unfortunately, They don't give you a big lag time. They'll call you about 24 hours before your surgery. So typically the day before. If you happen to be having surgery on a Monday, they'll call you the Friday before. So again, additional planning. Pre-op will tell you nothing to eat or drink from midnight the night before. They may also tell you nothing to eat or drink from 10 p.m. the night before if you're one of the very first cases in the morning. Okay, they'll also indicate to you, they'll go through your medications that are on your medication list, and they'll tell you, Mrs. Smith, I need you to take this medication the day of surgery, but hold this one. So they'll give you specific information on the medications that you currently take that they can visually see. In the event you ever have questions or concerns, you don't maybe remember what they told you, you could always give us a call. We do have that in a printed document that we can give you additional instruction if necessary. Removing all jewelry, I always tell everybody, if there's anything, that you own that you really would be dissatisfied or unhappy if it went missing, please don't bring it here, okay? You move to a lot of different places throughout your stay, and things can and do get lost. So a couple other things. We are going to go really quickly over this. This is your showering kit. It's kind of additional infection control or additional infection prevention that we like to have you do and prep before surgery. I'm going to just quickly go through it. There are instructions in this bag, so you could read it 10 times if you need to at home, but I'll quickly go over what we expect you to do. You'll need this bag both the night before surgery as well as the morning of. You're going to be here, if your first case of the day, we usually like you here around 5:30, 6 o'clock in the morning. So one other thing, if you're somebody who happens to be traveling, say, from Grand Rapids, let me know that. I can give you a 1-800 number, and we could maybe help you to accommodate staying a little bit closer the night before if you don't want to wake up at, dark 30 to get here. If you are, though, requested, to be here at 6 o'clock, keep in mind we are going to ask you to shower the morning of, too, so allow yourself time for that. The very first shower that you're going to take is the night before. You're going to get in the shower, do your normal routine, what you would just normally do, but take this in with you. Once you're done, get it wet, soapy, and scrub from the neck down, front and back. You're going to leave it on for about 2 minutes. You're going to rinse it off and get out of the shower just like normal. Okay, use a clean towel once you're out of the shower, not one. Some people tend to use their towel for a couple days in a row. Let that not be the case for this one time. A clean towel, okay? And then also in here, there's a mouthwash. You're gonna use the mouthwash just to swish and spit after you brush your teeth the night before, okay? The morning of, you're gonna repeat the same exact process. So you're gonna wake up, you're gonna shower. One other thing I forgot to tell you. After your shower, make sure you have clean sheets as well. We want you getting into bed the night before your surgery onto clean sheets so that you don't bring any contaminants that could have been onto your sheet or on your sheets back onto your skin, okay? Again, the morning of, you're going to repeat the exact same process. Hop in the shower, suds this up front and back for 2 minutes. Don't use it on your hair, your face. It's really drying. Rinse it off, and then also use the mouthwash, okay? As far as these two products are concerned, any questions? Okay. One additional thing that is in here is this incentive spirometer. There's going to be some slides down the way that go over the incentive spirometer, but since we're on it, I'm going to go over it really quick. This incentive spirometer is part of your infection control kit because what it does is it's helpful for us in preventing post-operative pneumonias. If you happen to be a smoker or anybody with any type of lung disease, it's also beneficial to use this up to 2 weeks before surgery. So that's why we give it to you before your surgical case. We also ask that you bring it back with you the morning of, the day of. If you forget, no worries, just tell us. We have lots more. We'll make sure that we give you one. The way that you use this is it's actually like a big straw. So you're not going to blow into this, which a lot of patients pick this up and that's what they do. The first thing is they want to blow into it. It's actually like a really big straw that you're going to just suck, like you're sucking through a straw. You're going to notice a couple things are happening with this apparatus when you do that. The first thing you're going to notice is this disc here starts to travel up the column. It's another thing that I see patients do all the time, which is really not effective. They tend to do this and try and blast this to the top, and they're not really paying much attention to what's happening over here. And really what's happening over here is more important. What you want to do is keep this little bobble floating between these two arrows for as long as you can, and then let it out. We're going to want you, when you're here post-op, to do this exercise about 10 times every hour, but I don't want you to do it 10 times in a row. If you do it 10 times in a row, you're going to feel yourself becoming lightheaded, okay? Another thing, after you use it, I want you to cough. This is meant to loosen secretions to help you cough them out a little bit easier. Okay, quick, I'm just going to show you this floating between the two arrows so everybody kind of understands how it should work. And you see how this is not really going very far, but I'm keeping this floating between the two arrows. So that's what you're going to want to do when you're here. Feel free to practice all you want at home before you come. That's it for night before. One additional thing, though, that I do want to tell you, because we consider it part of planning, is refrain from smoking. So if you are a smoker and you do have time, maybe your surgery is a month from now, work on quitting. Work on cutting down, even if you can't quit. There is research out there that shows us that spine fusion failure is roughly 4 times greater for those of you that are smoking. So you wouldn't want to undergo this entire experience of having a spine fusion surgery and find out, 6 months to a year down the road that your fusion did not heal. So, trying to cut back, even if it's cutting back and not quitting, is a really good thing to do. Remember, though, that nicotine is in so many products these days. It's not just cigarettes, but e-cigarettes, pipe smoking, chewing tobacco. So once you're an inpatient, you're going to have access to a lot of our spine team members. There's nursing, there's physician's assistants, there's nursing assistants, there's your surgeon, there's residents. This is just a way of introducing you informally to your soon-to-be, caregivers. One important thing, I guess, I would take away from this slide is that you and your family are a really important part of our spine team members. Effective communication is the best thing that you can do for all of us. So, if you're in a room and say something doesn't go the way you envisioned it or the way you wanted it, honestly, effective communication and letting us know is the best way that we can help you to make it right. These are our goals. Again, I don't really need to read these for you. I'll let you take a second to just take a peek. But, obviously always treating you with courtesy and respect and hoping that you get the best experience and the best outcome from your stay here is our targeted goal. So we're going away now from the planning portion. I'm going to move on to what we call post-op day 0. Post-op day 0, we refer to that as your actual surgical day, the day you have surgery. So if you ever hear us saying post-op day 0, that means the day that you're here and the day that you're actually going to have your surgical procedure, okay? These are some things that all of you can expect to have. I always tell my patients, plan on having all of them, and when you wake up with just an IV, be really happy that you don't have the rest. So plan for all of them. An intravenous catheter, that's pretty self-explanatory. Everybody in here will have that for sure, without a doubt. It's how we give you IV fluids. It's how we give you pain medication, anesthesia medication while you're in surgery. The next one is a urinary catheter. You may or may not have a urinary catheter. There's a couple factors that weigh into this. The 2 primary ones, though, are your surgeon. Sometimes your surgeon will just opt to use it while another surgeon won't. The second really big factor is what type of surgical procedure you're actually having. If you're having a small 1-hour surgery, your surgeon may opt to not undergo putting in a urinary catheter. One thing I think most patients are interested in knowing in regarding to the urinary catheter is, are you awake when it's inserted? And truthfully, you're not. And if you are, you're pretty groggy. You don't really care that we're inserting it. So it's essentially painless because you're not aware. We do make every effort to remove this catheter on the day of surgery, okay? Sometimes we do need to leave it into the following morning, but our general guideline is to remove it the day of, so you don't have it for very long, okay? A dressing or a drain. Everybody will for sure have a dressing after surgery. The type of dressing is variable depending on your surgeon as well as your surgery. A drain is one of those things that's hit or miss. Some surgeons use the drain, others don't use the drain, and sometimes if there's a more extensive surgery, there just becomes a need for a drain. The one thing I can tell you is nobody goes home with a drain. So that is one of those factors that could potentially keep you here an extra day. You know, if we find that the drain continues to drain, we won't pull it until we're sure that it's finished, okay? Leg compression devices, that's these green things. So these are sleeves that just go over your calves. Every patient utilizes these while they're here. Even if you're an outpatient, they'll put these on during the OR. These just inflate and deflate one leg at a time, and they help to prevent post-operative blood clots. So everybody gets those. Oxygen, you may or may not remember, everybody really does have it sometime during your surgical course, but most people really don't remember. It's taken off in the recovery room and you never know that you even had it. And a bladder scan. So this is something all of you will experience regardless if you're inpatient or outpatient. We use bladder scanning in the preoperative area. We'll ask you to urinate. We'll have you come back to bed, and sometime within a 30-minute period after you've already gone to the restroom for us, we just take a quick ultrasound of your bladder. Just helps us to know how much your bladder holds in there after you've already urinated. Okay, it's not such a real important number for you, but it means a few things to us, so we like to take a look at that before you actually have surgery. Okay? Some of you will actually get it after surgery as well. Most of you will not ever see a bladder scan again. Additional medical equipment. So we did go over both of these. We talked about STDs. We also talked about the incentive spirometer. Any questions with any of that content? So still on post-op day 0, this slide pertains more to our expectations of you. So we started a new initiative last year in February where we make every effort to get every patient up on the day of surgery to walk. This is regardless if you're having a really minor spine surgery as well as if you're having a more complex multi-level spine fusion. We find that walking is one of the best things that you can do after spine surgery to help augment healing and get you back to a functional level. Okay, it's going to help to decrease the incidence of what we call post-operative ileus, or where your bowel just is too sleepy and doesn't work. It will decrease your incidence of actually being somebody who can't urinate effectively after surgery. Helps increase blood flow to the area of the actual incision, so we'll augment healing in that way. Also will help to prevent postoperative stiffness, which is very common after surgery. It's pretty inadvertently, surgeons have to cut through some of the musculature in your spine to get to your spine. So muscle spasm is pretty common, stiffness is pretty common, so getting up and moving is the best thing you can do for yourself. I'm gonna tell you probably 10 times in the talk, and then I know when Allison gets here, the occupational therapist, she's gonna tell you probably 20 more times. So this is an expectation after surgery that everybody walk on post-op day 0, okay? Let's see, so you're gonna also have restrictions. The restrictions are also the same regardless of what type of surgery you're having. We say a mnemonic trick, no bacon and lettuce and tomato sandwiches with 2 pickles on the side. That acronym stands for the B is no bending, the L is not lifting anything greater than 10 pounds or a gallon of milk, the T is no twisting, and the 2 pickles on the side stand for pushing and pulling. Again, regardless of your surgery, you'll all have these restrictions for somewhere between 6 to 8 weeks. Your surgeon will always trump me. However, if they tell you after 3 weeks that you're good to lift those restrictions, as long as it came from your surgeon, that's who I would go with, okay? Again, we offer, just as far as lumbar surgery goes, a really helpful thing for our patients to know is that, number one, none of you will be able to sleep on your stomach. It'll be back or side lying. And when you are sleeping on your side, a pillow between your knees is really helpful. It keeps your spine in a nice neutral alignment. And if you happen to be somebody that inadvertently kind of slumps and rolls kind of forward when you're on your side, that kind of simulates twisting. So when you have a pillow between your knees, it makes it much more difficult to do that without becoming aware of it. Coughing and deep breathing. So again, that's going to be where that incentive spirometer comes in. That's all part of coughing and deep breathing. A clear liquid diet, you're probably not even going to notice. It will be a really brief time that we make sure you're not having nausea and vomiting after surgery, and then your diet is advanced relatively quickly, within hours, honestly. A bladder scan, if necessary. Again, most of you will not see a bladder scan other than in the preoperative area, unless it becomes necessary for us to recheck because for some reason you're not urinating. And then again, removing the urinary catheter, you know that it is on day of surgery. We make every effort to remove the urinary catheter on the day of surgery. One thing we would never want anybody to do is for fear of getting up and walking to the bathroom, you would want to keep a urinary catheter in. Never a good idea. We want to get it out as soon as we can, okay? So we talked about day of spine surgery. Do I have any questions on that before we move to the day after spine surgery? No, you don't need to do any additional bowel prep before surgery, no. We will help you after surgery, though, to have regular bowel movements. Stool softeners are part of the postoperative protocol, and everybody gets put on a stool softener. Okay, so now we're starting, you know, you had your surgery yesterday, and you're waking up today as post-op day 1. First and foremost, I want to tell you, if you did not walk on the first day of surgery, you are for sure 110% walking on the day after surgery. But honestly, we do make every effort to get every single patient up on the day of surgery unless your surgeon tells us he doesn't want you up the day of surgery, okay? So please help us to keep that goal because it's best for you, I promise. Sitting in a chair for all meals, this is another expectation. You know, it's just one additional way of getting you up in a chair for all your meals, getting you up and moving and getting you mobile. Also getting up and going either to a bedside toilet if you couldn't get all the way to the restroom, or, you know, frequent trips to the bathroom. If you haven't walked in the hall by now, we at least attempt to get you up to the door of your room and typically out into the hall. Physical therapies as well as occupational therapy are really good with getting you up and moving. Again, on post-op day 0, so day of surgery or day after surgery, you're gonna possibly get a visit from either physical therapy or occupational therapy. I honestly can't tell you if that's gonna be day 0 or day 1. It just depends what kind of time is allotted. It depends what time you get back from the operating room, as well as if that's something your surgeon has ordered from you. But expect it on either day of or the first day after surgery, okay? Dressing changes, we typically won't do a dressing change unless your dressing is soiled. So if it looks like it's starting to get shadowing or, you know, that you're oozing and we can actually see it coming through the dressing, we'll change it then. If we don't find that, we'll just leave it intact and we won't touch it. Bathing instructions, just know every single person here has the eligibility to shower even the day after surgery, unless you have a drain. If you have a drain, we're gonna ask you to not shower until the drain is pulled. But you know, we have the ability, we'll help you to cover that incision and get you up and in the shower. If it's something not offered to you, and by all means, if you want it, just ask. Somebody will make accommodations for getting you into the shower and helping you out. We have shower chairs in every room. You should be able even to sit in there if that's what's necessary. Okay. Clean sheets. That's another thing that we'll be doing here daily, is making sure that your gown is changed every day. And if you have soiled sheets, maybe from drainage that came from your back, we'll make sure that those are changed. That's another thing that at home, we're gonna want you to continue that trend. Changing your shirt and putting a clean shirt on daily, as well as changing your sheets if you know they're soiled. The urinary catheter. So again, if that wasn't removed on the day of surgery, usually by about 6, 7, 8 o'clock in the morning the following day, we do get that out. And then a drain. If your drain is ready to be pulled, we'll pull it for you. If not, that will have to stay in place until the drainage is fairly minimal. Multidisciplinary rounds. The biggest point of having this slide here is to let you know multidisciplinary rounds is the time of day when your surgeon, as well as the resident, any caretakers essentially that will be seeing you throughout the day, they make their rounds and they discuss your case on an individual basis. The biggest thing to take away from this is it can be really, really early. I know without fail, Dr. Shadid is a surgeon that rounds at 6 a.m. every morning. So if you want a significant other to be part of that, it's probably best if they stay overnight, which that is allowed. All of the rooms will accommodate at least one overnight visitor. You really don't have to make individual accommodations. We'll allow for that. It's just a couch, but it is big enough for any loved one to stay. Again, so this pain slide is just, a lot of people are under the perception that they're going to have their spine surgery and wake up and everything is going to be solved. Sometimes, you're lucky enough to be one of those patients that a lot of your symptomatology is gone or at least improved. But you got to keep in mind you did just have surgery. So regardless, some type of pain is expected after surgery. You've just had some type of incision done in your back. You have a bunch of muscles that sometimes have to get cut through. Some of you will have instrumentation put in your back. And others, it's a minimal incision, but you were still, musculature and such was still cut through. So expect some level of pain. It would be impossible for us to make you pain-free without really getting you heavily sedated. So we're going to work with you to keep you at what we would consider managed pain. And we'll talk about that in the next couple slides here. Again, moving, we talked about that already. Moving is going to be one of those prime factors that really does reduce your pain. It may not seem like initially, but the more you do it, the less and less stiff you become. Frequent position changes is going to be a really key thing for you too post-operatively. Every 45 to 60 minutes, we're going to want you to switch things up a little bit to prevent post-op stiffness. Yeah, we do have patients that, when they're going from a sitting to a standing position, that's typically when they say, or sometimes when they're laying in your bed and you have to sit up for the very first time, that tends to be the time that's most painful. Nursing staff really does try to work with you to get medications timed, occupational as well as physical therapy work with you to help you, learn the best techniques for getting in and out of bed, getting in and out of a chair, so that that type of pain is reduced somewhat. One thing that we do use here, it's called the Wong-Baker Faces Pain Rating Scale. You'll see there's some faces, like happy faces or sad faces across a grid. The one thing I like about this board is it goes into a little bit further explanation as to what those faces mean. Maybe if you're somebody who's having really, really intense pain, you're inclined to tell your nurse, I'm having a 10. 10 out of a 10 is my pain. If you really look at what a 10 is, a 10 means that your pain is so bad, you're passed out. So nobody's going to be there. Take a look at the faces, take a look at the wording. Know that we want you to be around a 4. 4 reads that your pain can be ignored if you're busy, but it still gets your attention. Just take note that it doesn't say pain-free. Remember there's a difference between managed pain and pain-free, and we're going to do the best we can to work with you to keep it at that level 4. Sometimes we need to do a little bit of playing and mixing up of, or changing medications to find the right mixture for you, but eventually we get it right and you go home on oral pain medications, okay? One other thing that I want to mention really quick, keep in mind that pain medication, the nurses usually night of, sometimes even into the next day, they're pretty good with giving pain medication on a fairly consistent every 4-hour basis. But no, it's not really scheduled that way, not opioids. We keep those on an as-needed basis. So if you find you're having pain maybe at 3.5 hours, it might be a good idea to just let your nurse know, give her a heads up, when my next dose is due, I'm going to need it, so she can anticipate that need and get it ready and get it prepared. But know that it's never really ordered on a scheduled basis. That's something you typically need to ask for, or your nurse has to be really in tune to do. One way you can do that is on the back of this board. We can write, what are your scheduled pain medications? That might be your muscle relaxer. A lot of times that's ordered on an every 6 or every 8-hour basis, and that comes pretty regularly, but that narcotic is not ordered that way. So help us to help you and let us know what type of pain you're having, maybe before you're actually getting to that point where it's a little bit difficult to get it under control. This board is really useful for that. We just talked about that. A stool softener is always ordered as part of your post-op medication regimen. Not to mention, we're going to keep telling you drink 8, 10, 12 glasses of water a day. It's going to help to get your bowels going again. Walking is going to help with that too. The more you walk, the more apt you are to urinate as well as have a bowel movement. A PCA, so this is one additional type of pain administration that we do use. We try to use this for short periods of time only. This is called a patient-controlled analgesia pump. Some of you come from surgery with one of these if your surgeon has deemed necessary. The nice thing about this is it allows you to have a little button and you have a little bit of control over when this pain medication is administered to you. You push the button and some type of desired amount is delivered to you. Roughly, I think the lockout time is like every 10 minutes. There's no way that you can overdose yourself with this either because it's timed and it's calculated to an appropriate amount for you. The drawback with this is it's really immediate, effective pain control, but it doesn't last long. You metabolize it really, really fast. So it works great, but then you're having some pain again. Works really good, but then you're having some pain again. So what we tried to do is get everybody onto oral medications because it's a nicer, much more sustained level of pain control. Not to mention nobody can go home with an IV and a pain pump. So, you know, our goal is always to transition you to oral pain medications that work for you for home. Sometimes, like I said, it's trial and error. We might have a patient that gets nauseous from one type of medication. So sometimes we do need to play with it a little bit, but we eventually figure it out and send you home with oral pain meds. We talked about the Wong-Baker Faces Pain Rating Scale, so I'll move to the next slide. Infection prevention. So this is also an important slide because when you go home, we're going to need you guys to take a look at that incision every day to make sure that it is in fact healing. You're going to be looking for additional redness, swelling, maybe drainage after day 3 or day 4, and fevers. But before you would ever come in contact with your incision, you're going to really want to make sure that you use meticulous hand washing. Another thing we kind of talked about this was putting new clean shirts on every day. We talked about changing those sheets before you come so that you actually have, you know, clean sheets to sleep in the night before surgery. Then you'll be coming home to clean sheets as well. And then one additional thing would be, you know, a lot of us have that tendency to let our pets sleep with us. Immediately after surgery, probably when you still have that wound, would be the one time that I would say, you know, let that heal for about 2 weeks, and then once all of your, you know, your staples or your sutures or steri strips have been removed, then you can let your pet back in the bed. Discharge planning, this is something, you know, I kind of contemplate even switching the location of the slide because discharge planning is something that actually starts from the very time you get here. We start anticipating what your needs are. Are you somebody who lives alone maybe? Somebody who has stairs in your home maybe? So we do try and make those accommodations throughout your stay so that, say you do have stairs in your home, we'll make sure Allison knows that and she'll go through a dry run of stairs with you. You know, if you are somebody who knows you have no, you know, significant friends or loved ones to go home to, we may be looking at a subacute rehab facility, you know, if that applies to you. So those things start as soon as you're here. The main focus of this slide is also to keep you guys in the know of identifying a ride home. That really should be something that takes place before you ever step foot here. Nobody really can go home driving independently. We do need you to have a ride home. Typically discharge is about noon on the day that you're told you're going home. And usually we do try to give you a heads up. You know, the day before you're going home, we'll let you know, Mr. Smith, you're doing pretty good. Tomorrow might be the day that you go home. So planning on your part is really essential so that you have a ride home before you go. Case management. So this is one of the members of our team who will help. Say Allison decides that you need a little bit of help, you're a little bit unsteady when you walk, and maybe you need a rolling walker. She lets case management know that, and they're the person that gets those types of things set up for you so that you have what you need when you go home. Okay, including if you happen to be somebody who maybe needs a couple nursing visits, or maybe you need some additional physical therapy at home, or maybe you're even somebody who, like I mentioned earlier, needs a subacute facility. Case management is the person that helps you with that while you're here. Again, your spine surgery, the recovery is definitely a team effort. All the things that we ask you to do here when you go home, they're going to be expected for you to do there too. You know, walking every 1 to 2 hours, even if it's just minimal at first, we just care that you're doing it frequently. Frequent position changes every 45 to 60 minutes is going to be beneficial for you during your waking hours. Maintaining those restrictions of no bending, lifting, twisting, pushing, pulling, making sure that you're looking at your incision every day for signs and symptoms of infection to make sure that you catch that before anything would get out of hand. Taking your pain medications as scheduled, but never more frequently. And the best thing to do if you ever have pain medication questions, if a pain medication is not effective when you go home, never double up. You're always going to want to call the clinic and let them make a medication change for you. One last thing, when you go home, you may or may not get a survey in the mail. We really do appreciate your feedback regardless if this is good feedback or bad feedback, because anything we get of that nature helps us to change our program, make it better for the next group of people who are coming in to have spine surgery. Thanks again for coming, and I'll see all of you once you're here as inpatients.
Thank you.
Thank you.